Welcome to This Week in Health IT. It's Newsday. My name is Bill Russell, former healthcare CIO for a 16-hospital system and creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Special thanks to Sirius Healthcare, Health Lyrics, and Worldwide Technology, who are our Newsday show sponsors, for investing in our mission to develop the next generation of health IT leaders. We set a goal for our show, and one of those goals for this year is to grow our YouTube followers. We have about 600 plus followers today on our YouTube channel. Why, you might ask? Because not only do we produce this show in video format, but we also produce 4 short video clips from each show that we do. If you subscribe, you'll be notified when they go live. We produce those clips just for you, the busy health IT professional. So go ahead and check that out. We also launched Today in Health IT, a weekday daily show that is on todayinhealthit.com. We look at one story each day and try to keep it to about 10 minutes or less, so it's really digestible. This is a great way for you to stay current. It's a great way for your team to stay current. In fact, if I were a CIO today, I would have all my staff listening to Today in Health IT so we could discuss it. You know, agree with the content, disagree with the content. It is still a great way to get the conversation started, so check that out as well. Now, on to today's show. Today we are joined by Mari Savickis, VP of Public Policy with CHIME. Good afternoon, Mari, and welcome to the show.
Well, thank you, Bill. Thanks for having me.
Yeah, well, I'm looking forward to it. You're working out of your house? Pretty excited about working out of your house?
Yes, broadcasting live from the amazing headquarters of Fredericksburg, Virginia. So exciting. I know that you and I discussed having a beach background, Bill, because in my fantasy world where I like to live, I'm at the beach, but instead I'm here in the cold tundra of Virginia.
Yeah, is anyone getting up to the hill these days? I mean, we had the event that was there. The National Guard is still there. Does the team actually go up there much these days, or is it still pretty locked down?
Oh, it's locked down. We're not going up to the hill. You don't get, there was a little bit more flexibility before the insurrection, but no, we're not going to the hill.
Yeah,
it's very tightly controlled.
So you just like everybody else has to figure out how to do your job remotely and interact with the key players, gather the information, and get it represented up on the hill. You know, actually, before we jump into it, I'd love to hear just a sort of a picture of what transition looks like. So my picture is that almost everything comes to a stop around the election. Everyone's sort of waiting, and then the election's, decided, and then things start at a frenetic pace. I mean, you have most presidents are judged based on their first 100 days. That's just sort of the way it is. What have you accomplished? What direction have you set? So I'd imagine things just set out in a pretty hectic pace. Is that generally what happens when a new administration comes in?
It is, though. The handoff this time, I think everyone knows, was much more complicated. So the transition starts very early on, and as in it should have happened last year into the beginning of this year. But I think this is well documented now that the transition was very bumpy, and it has set things behind. For a while, the transition officials weren't allowed access to the previous administration. So things are a little bit behind, but I think they're playing catch up. And, every president looks to make their mark during their first 100 days in office. And we've seen a blizzard of executive orders trying to walk back some of the last administration's policies. And one of the things that happens is, and this happens no matter, it happens pretty commonly when there's a handoff from one administration to the next, particularly from when it's going from, one party to another party, is that they're going to hit pause. They're going to hit pause, and they're going to take a look at what's actually in the pipeline and what was recently released, and they're going to, maybe pull things back. So we're waiting on, a number of things to just see how that shakes out. Like, for example, the HIPAA rule was released. I forget what day it was, maybe the day before the inauguration, and maybe it was the day of. And we have no certainty as to whether or not, is this going to get pulled back? We can't get an answer from the Office for Civil Rights, and it's probably because they don't have all their transition officials in yet. The new administration's not yet in place. So yeah, it's a little bit hectic right now, but I think they're picking up steam, and they're busy, clearly busy.
I've talked to people in several administrations, actually. I know it's hard to believe that I actually know people in administrations, but they they will say to you that what they want to do is get to this sort of normalcy and sort of portray that everything's under control. But in that first 100 days, it's just every day is like chaos. It starts perfect at like, 7 o'clock, everything's okay. And then by like 8 or 9 o'clock, everything's out of whack, and you're just scrambling to make sure things don't spiral out of control. So I mean, that's the nature. But you have a president who's been a vice president, and hopefully can surround himself with some people that know how to navigate that. It actually, I saw a story where he's already reaching out to Rahm Emanuel, who was Obama's chief of staff, and that's the kind of thing when you have that kind of experience coming in, maybe they can get through it. Let's start with. I'd love to talk a little bit about your team and hit a couple regulatory things. We're going to hit some stories, and I think there's some fun stories that will give us the backdrop to talk about some things that are really pertinent to health IT. Let's start with your team. Who's on your team at CHIME that's working the federal affairs and congressional work?
Sure. And, this is an interesting time for the team because we onboarded them all remotely in last March. So they actually started right as the pandemic was picking up. And so none of them have actually met each other in person. And in fact, I haven't met our administrative support, Lauren, I haven't even met her. She's in Michigan. So we have Cassie Leonard, who is our director of congressional affairs, and she comes by way of Senator Kennedy's office, so right off the hill. And then we also have Andrew Tomlinson, who is our director of federal affairs, and he is handling all the work with the agencies, and he comes by way of ONC and then a brief stopover at United. So they both bring a really deep bench, and they're pretty darn fabulous. And I'm so fortunate to have them. And, we've been able to increase our bandwidth with the addition of the three individuals.
Yeah, is there like a words per minute they have to be able to read in order to take those jobs?
Right. I know, right? You must be able to devour regulations and statute at like an alarming rate.
Yes.
No, nothing like that. So that's an interesting idea.
Well, you guys are keeping CHIME membership abreast of things that are going on. There's some interesting things right around the corner. Information blocking, April 5th is the first deadline. Anything going on with regard to that, or what are you guys keeping an eye on there?
Yeah, we actually have a ton going on. So, we're really fortunate that we were able to advocate for some delays for our members. That was incredibly important, especially in light of the pandemic, and it's afforded them some additional time to meet this compliance deadline. And while some we were told were ready in November because they felt like they had no other choice, we know that some of our members were still struggling. And we actually have a survey out right now just to kind of get a better finger on the pulse of just how many will indeed be ready. So we're focusing our efforts on education. And in fact, tomorrow we are launching an information blocking center in conjunction with several other provider stakeholder groups that we work closely with, which is really exciting. And we're going to be able to direct our members and their members to a single, what we want to call like one-stop location for their education. So we're pretty excited about that.
No, that's fantastic. I think the other thing that is top of mind, and we're going to do a story on vaccination. You pulled a great story from the MIT Technology Review. So we'll go a little back and forth on the vaccination, but talk specifically a little bit about what's going on in the Hill around the vaccination, and maybe focus in on health IT for that topic.
Well, there were actually two hearings this week. So the House Oversight Committee and the House Subcommittee on Health, both Energy and Commerce committees, they had some hearings this week, and we're still reviewing them. I don't know that there's necessarily an enormous focus on healthcare data, but I can tell you that the stories that are percolating up from the field are that not everything is going swimmingly, which I know that no one will find that shocking given our antiquated data reporting infrastructure for public health. It's something that we continue to push for more investment in. And while we did get some money in the stimulus packages last year, it's still, it's still an investment, but we need more funds to help strengthen this. And I guess like what better time to test out, our pipes than during a pandemic. So it's been a challenge. And the CDC has a requirement that you have to submit the hospitals have to send their data up or I guess the state sits in between it, but within 24 hours. So you have to send it up. And so that is creating challenges when you have to do things at like a really lickety split pace, and you have certain information you have to collect, and you do this quickly, and you do it on paper records. So you know what happens when we use paper records. So it has been a challenge.
Why? I'm sorry. Why are health systems using paper records?
Is this, I know, is this like a needle across the record moment, Bill?
I just, I'm kind of surprised. I mean, we had meaningful use, which started,
Yeah.
I don't know, like over a decade ago. I would think that almost all the health systems are using some sort of electronic tracking for this. And if not, I mean, they're just asking for challenges, aren't they? I mean, they're going to have to turn paper into electronic to send it back to the federal government. Is there, I mean, am I missing something?
I mean, I don't think that the providers really want to start dropping back to paper, but you have the current reality. It's like, shots in arms, and they need to be done as quickly as possible. And you are collecting information that's required by the state. And so what they're doing is they're taking the paper records and the information they collect on site, and then they're later keying it in, which again would be after the 24-hour period. And so they don't have, the ability to work, I guess, that quickly, collecting every single data point, keying it in. And so what's happening is that in some cases, the data is getting communicated up to the state. And we have examples where the state is not absorbing that data. And for example, one member told us that the state requires that the patient's identifier number and the electronic record number be included, and it wasn't included. So they were basically, several thousand records were put to the side. And the only way that the provider found out was by doing, a quick spot check to see if they were actually there. And then they weren't. And so there are these issues that are happening. I don't think any provider is like, oh yeah, I should totally drop back to paper records. That's a great idea. They're just trying to, do the best they can with the requirements that have been placed on them. And again, work expeditiously through the system. The other issue too that we've heard is, so if there's not an accurate tally in the database that the state holds, which is sort of, determines how many vaccinations a provider gets, then you may be looking for more vaccinations because you actually administer them, but the state may not have that reflected in their database. And so that affects your number of vaccinations sent to you. And so then we have one member who told us they actually had to close their clinic.
Right. For vaccinations. Yeah. I mean, the number of vaccines going to places. So the thing I was, and by the way, if people are listening to this going, why is the interviewer going back and forth? Because this is a Newsday show. This is what we do on the Newsday show. We go back and forth. So it's interesting because I talked to several health systems today, and, just through the course of my normal work that I do, and I asked them about vaccinations, and the two phone calls I had today, they were like, hey, it's going great. We integrated this. We have QR codes. People are showing up. They're in and out within 10 minutes. The information's going right into the EMR. It's generating the reports. We're sending it up to the state. Now, everyone in the world will tell you that the states are notoriously underfunded from the public health side. Their systems are kind of a patchwork kind of thing. And sometimes they can take the data and they're underfunded, understaffed. So they are going to set aside 7,000 records and not let you know. So that kind of stuff happens. Nobody doubts that. They also, sometimes you struggle. You send them information the way they tell you to send it to them, and it doesn't go into their system correctly and falls by the wayside. All that stuff does happen. I'm not denying that, but I'm wondering why some health systems with their EMR are able to set up pretty efficient processes while others are struggling. Is this an education thing? Is it a different EMR thing? I'm not asking you to answer it because I'm not sure you have an answer for it. I'm just sort of wondering out loud what makes one health system able to do it and another health system not. Anyway, I will move on because we're going to come back to vaccine a little later. Anything around cybersecurity? I mean, there were so many very visible incidents leading up to the election, and that didn't really slow down after the election. There's still a lot of things going on in healthcare. What can we expect? What are you keeping an eye on, or what's the movement right now around cybersecurity?
It's hot. I mean, it continues to be our hottest policy priority, and year after year, and it hasn't abated. So the challenges are, I think they're well chronicled and well documented, but we have a lot of problems. I'd say that, while the health sector, which is one of many sectors across the country, we've got like energy and banking and retail, healthcare is one of them. And we've been behind the eight ball, but I think we've been working hard the past few years to catch up. That being said, we still have challenges. Even the best resourced members that we have still have, issues. And so we have a constant barrage of cyber attacks, and they increased exponentially in 2020 when the pandemic started because people are opportunistic. And there were two major issues that happened last year. There was a credible and active threat that pretty much brought the industry to a standstill the last day of October. And so that had everyone in an extremely high alert, and several hospitals did actually get attacked. There's, ones that were in the news, like there was a hospital in Vermont that was brought down for several days. And then there was, then there was also the solar winds issue. And so it hasn't really abated, Bill. I mean, there's a lot of attention that's being brought to bear on cyber. And I think that there's a bipartisan consensus that this is an issue that warrants additional attention. And, we're going to keep fighting for additional funds for our members.
Yeah. And we're gonna start with a HIPAA story. My thing on cybersecurity, I heard somebody say this once, that and it resonated with me. He was like, these nation states and these crime syndications are essentially attacking our corporations in the United States. And he said it's the equivalent of they've all set up aircraft carriers off the coast, and they're just flying in and doing runs, and they're shutting down places, they're stealing money and that kind of stuff. And his premise was, if that were actually happening, if aircraft carriers were off our coast, we would mobilize and do something about it. But in cyber, for some reason, we haven't up until now really mobilized enough to protect. And we were sort of saying, hey, every health system has to come up with their own plans to protect themselves, and every corporation has to come up with their own plans to protect themselves. So I'm really hopeful in this space that we see movement, and I'm glad to hear that it's bipartisan, that we really need to do something to protect organizations like our hospitals who function in the U.S. All right, you ready? Sure.
Before we move on, Bill, I would like to share, I'm going to try to insert some good news into our conversation, because it's not always, bad news. At the very, I guess it was the end of last year, beginning of this year, probably one of the last bills that President Trump signed was HR 7898. And, this may have been maybe overlooked by some folks, so we try to get the word out. This is a really good bill, and we're very happy that it was signed into legislation. It's going to give our members, the provider community, credit for using cybersecurity best practices. So when, OCR, the Office for Civil Rights, starts considering maybe like the length of an audit, they're going to have to take into consideration whether or not a hospital system or provider was actually using some best practices for the last 12 months. So this is really a nice step in the right direction, and more of a carrot than a stick. And we've been trying to find ways to provide more incentives rather than penalties to incite the right behavior. So we're really pleased about this.
No, that's fantastic. It's cybersecurity is one of those things that is so challenging, and you need a fair amount of funds to stay up to date and stay ahead of it. And actually, that takes us to our first story. Our first story is the Fifth Circuit Court of Appeals vacates the MD Anderson HIPAA penalty. And this sort of speaks to some of that, right? So essentially what happened here is the circuit court vacated the penalty. They vacated it for a couple of reasons. One is they said that the health system had mechanisms in place to encrypt the PHI on mobile devices, but it was the employees who failed to use the encryption control before the laptop and USB devices were taken. Therefore, the health system had done their duty and had done the things they were supposed to do. And so they vacated for that reason. And they also said that the penalties were, I think the word was like capricious, and these were words they used, arbitrary and capricious, in that the OCR was not enforcing their penalties evenly across all health systems. So they vacated that penalty, and I think it was $4.5 million to MD Anderson. So that's been vacated. You pulled this story up. What are your thoughts on this story?
Yeah, this is another morsel of goodness that I feel like got lost in the shuffle of the madness of January. And, we only saw like one or two articles on it, and we're like, whoa, this is a really big deal. So it actually is, in some ways, just similar to that bill we just discussed. Is that we're going to have to put the bill in place, right? It's going to have to be operationalized. There'll have to be a rulemaking. People weigh in what's considered every little nuance of a best practice. But this is great. It says that, you have tried really hard, that the provider tried very hard, and there's never, there's never going to be a time where you're going to be completely inoculated from a cyber threat. That just is not going to happen. So I think that this ruling is very instrumental. The data in question goes back to 2013 and 2014. And, I'm glad that the provider fought, because some of the things we've heard from our members is that the audits performed by OCR, they're done by different auditors in different regions. They don't always look at the same things, and they sometimes can be fairly variable. But I think we'll have to wait and see how exactly we're able to operationalize this bill and give these providers the best, like, give them credit for the best practices. So I think this case will play into that. And I think it's really, really a good news story.
Yeah, it's by the way, I agree 1,000% with that. They when they say it's arbitrary and capricious, I think there is a certain amount of truth to that. So they have to go back to the drawing board and essentially say, okay, we need a uniform process for measuring this. You wouldn't send out, accountants around the country and say, hey, there's going to be, a little difference in the South and the West and the North and the East. You actually have standards that the CPAs study, and they follow those standards. Same thing should be true here. We should know that when they come into audit, they're going to be looking at these things, and these are the things we're going to have in place. So I agree with that 1,000%. I actually did post this on my LinkedIn, got a couple of interesting back and forths, and one of them was the Wayne Sadin, who's a transformational CIO, CTO, CDO, and he goes, my take as a CIO, employees fail to use the encryption control. He's quoting the story. He says, what CIO or CISO creates an encryption control, especially for a portable device, and double, especially for one containing PHI, then doesn't deploy it and enforce the use throughout the system? And what internal audit compliance function would let said CIO, CISO get away with that? And what CEO board, upon hearing of all this, worked or didn't work during regular IT cyber reviews, didn't order everyone to make it so? Employees can choose to encrypt PHI or not, ? And no fine for such systemic negligence. I sort of agree with that. Actually, this was one of my breaches, to be honest with you. When I was CIO, we had purchased a group. It was either a lab or a bunch of ambulatory surgery centers. And before we even got into them, somebody had backed up the information on a USB drive, put it in her purse, and her purse got stolen. Well, we had already purchased them, but we didn't go in there with our full IT on day one, and that happened like within the first week. So we lost that information, and so that was a reportable event. It was a finable event, and all those things. Now, and I understand, as a CIO, you're sitting back going, we had the things in place. We had encryption at rest, encryption in transport. We had iron key for locking down USB drives. We had all those things. We had just purchased this organization. We just didn't have a chance. And, and we ended up getting fined. Is that, I guess, under this ruling, they're going to have to step back and say, look, this is an extenuating circumstances. Yeah. They had all the procedures. They just didn't get in there.
That's exactly right. It's like, if you could picture a door, like, are 4 double bolts enough, or is it 5, right? So, the HIPAA security rule does give some latitude in terms of, like, how you establish meeting your security requirements. But that's also like another reason why CHIME and AHIS, one of our organizations that comprises CISOs underneath CHIME, has worked really hard to develop these set of cybersecurity best practices. They're known in the field as 405D, a super unsexy name, I know, so DC lingo, but they've been developed and they're voluntary, right? They're voluntary. Some they're also called HICCUP, another weird name, but either way, they're a set of best practices that CISOs and CIOs can deploy. And there's some that are for smaller to medium sized, lesser sophisticated, and then ones for larger ones. And so what this bill is going to do, and what this, hopefully will, I think, take into account what just happened with MD Anderson, is that we'll say, you're working hard, and cybersecurity, it's a journey, it's not a destination. So, some of these are maturity issues, right? And so you were saying you just bought the stuff, right? You were on your pathway you were increasing your maturity, but you were like a week, it happened the week after you bought the stuff and you hadn't implemented it yet. So it's about depicting that you are making an investment. Certainly providers who are not doing the right thing, and they've been like warned by OCR, and then they're like, you left the door unlocked. Well, no, that's not going to work. That is not going to work. So you have, that has to be like credible investment has to have been made in effort.
Yeah. The hard thing about that is I can hear people right now saying, we wouldn't judge banks this way. The banks are measured by their ability to keep our financial systems strong and that kind of stuff. If somebody were walking in, I'm going back to a Western here, we're able to walk in, blow up the safe and take the money and walk out. We wouldn't want to hold that bank accountable for not putting the right things in place. And I think there's a set of the population that's saying, look, the amount of breaches over the last, every year it's millions of records that go missing or just outright stolen from our systems. And I think we all agree we have to do better. And the question is it incentives or is it sticks? And, what I hear you saying is we need more incentives, because a lot of these systems are trying to do this without enough
we have a lot of experience with sticks and carrots, and like meaningful use is definitely a stick. And so what you're doing is you're skidding to the puck, right? So you don't want to establish a situation where you have like a checkbox. Some of our very strong advocates for better cyber will say you don't want to have a checkbox mentality, because that's not going to get you, it's not going to increase your maturity. You're just going to go check, check, check. And so that's not going to necessarily like result in the kind of security that you need. And so it is, incenting, we think, is a better pathway forward. Sometimes providers never like penalties. I'm not going to sit here and be like, oh yeah, we love penalties. That's like said no provider ever. Please bring me a penalty. I can't wait. No, but there's ways to, there's ways to do this. And but to just hammer them and just be like, you're going to have this protracted 2-year-long audit. You're going to be like, your head's going to be in a dark cloud. We're going to put you on the naughty list. It just goes on and on and on and on. And instead of focusing on like, here's how you could actually, improve yourself, it's more like you're dealing with some crazy protracted audit. And again, some are warranted, but we've been trying for years to try and move this ball forward. And again, it's a voluntary bill. These best practices are voluntary. So yeah. I don't know. I get so passionate about this.
Well, we're going to move on to vaccine. I will share one last story is, we had an internal auditor, and when I came in, I couldn't get my security team out from underneath the audits. They were essentially, the internal audit would do an audit. They'd give them a list of things they needed to fix. They'd fix those things. The next audit would come through. They get another list. They'd have to fix those things. And I finally went to the internal auditor and said, you have to give us a 6-month reprieve. No audits for 6 months, so that we can actually strategically get ahead of this. Otherwise, this is going to continue forever. You're going to find things, we're going to have to fix them, so forth. How about if we put a strategy together? We work with you on it. You can look at it, give us, some feedback, and then we'll put something in place. And that was a huge game changer for our health system to actually think about security strategically. And we changed almost everything we did as a result of doing that. And once you get on that hamster wheel, it's hard to get off, and it doesn't get you any closer to where you want to get to. All right, let's talk vaccine. As if that topic wasn't interesting enough, we'll get a vaccine. All right, so you pulled out an article from the MIT journal, the Technology Review, and this is how America gets its vaccines. I'm going to hit this real quick. So there's a handful of steps. There's a pre-step where there's two systems, Tiberius and VTrckS. Tiberius pulls stuff in, and it's actually a pretty state-of-the-art system. It was just developed last year. It has some really, really cool overlay stuff and whatnot. VTrckS is what we would call a legacy system. And there's an awful lot of uploading things via human interface, if you will, downloading them from one system and uploading them manually into that. So that's we're going to call that pre-step one. Step one is actually HHS receives regular updates from Pfizer and Moderna, as you would expect, and I guess soon J&J. Step two is HHS determines the numbers to send to each state. Right now, they're sort of hovering at about 4.3 million per week. And then Tiberius is used to divvy up the vaccine on the basis of census data. So it's a simple algorithm. It's not fancy machine learning. It just sort of looks at, the census data, says, hey, we're sending out 4.3 million, where we're going to send it. And that's what it does. Okay. So Tiberius pushes the figures around to other systems. It ends up getting to the CDC, where a technician manually uploads and sets order limits in VTrckS. VTrckS is something like an online store, if you think about it that way. And that's where orders are placed for the vaccine. And then we get to step three. Step three is the states and the territories distribute the vaccine locally. This is where it gets interesting. This is where it's, what's the best way to say this? So it gets to the states, and what's a lot of the article is pretty negative in terms of the states, and they've been underfunded, they're understaffed, and they're trying to get all this stuff. But anyway, it gets to the states, and then the states determine where it's going to go. It goes back up into VTrckS, which I think is, they actually put the addresses in there, and then it ships the vaccines. Step four is ships the vaccines. And actually, amazingly, this is the easy part. FedEx and UPS know how to do this. They've been doing this for years, and they ship it. And then step five is administer the vaccine and report back. And that's what we were talking about a little bit earlier. And that's probably where I want to start with you is, this is where the vaccine gets down locally. They're talking about the fact that the states are struggling to divvy it up. The scheduling systems are a little uneven. Some states are using Salesforce. Some Eventbrite is another one that's being used. Some health systems are using their portal. Some retailers, and I don't think retailers have a lot of the vaccine. They've been sort of tapped to do the long-term care facilities, but I'm not sure they've been opened up to do the general public yet. But they're going to use their retail portals as well to do that. But then you have to report back. And if you don't report back and report back effectively, then your vaccine sort of goes down. So that's a little bit of the lay of the land of the 5 steps from that article. And we'll share that link to that article in the show notes. All right. So you shared this story, you sent it over. What are your thoughts, and where do you want to take the conversation?
I'm perpetually an optimist, Bill. Okay. So I like to think that, everyone is really doing the best that they can do. Right. I mean, I'm sure you can find some bad apples and actors out there. And this is maybe me speaking personally, but I like to think that people are doing hard work during this difficult time. And so, there was a quote in here about there was a lot of money and effort spent to develop the vaccine very quickly, or vaccines, but there wasn't nearly as much effort spent on the distribution process. And this is really, you mentioned, UPS and FedEx, like this is a logistics operation, right? And so it's not all situations where, someone is maybe entering things manually and there's no electronic record. I mean, we had another member, for example, and this is it just varies. Every state's different in what they require. I mean, it's a morass of different policies cobbled together quickly to try to, get everyone vaccinated as quickly as possible. I mean, it's very, very difficult. But we just spoke to another member who has a very large EHR vendor that you would know, and they use their scheduling system to, to facilitate the appointments, right? But say you're not, they take all comers, right? So if you're not in their system, then they have to create a record for you. But at the point of when they reach out and say, I need a vaccination, they will look for you in the system, and they're picking up certain pieces of demographic information. But if they don't get enough and they don't get the right match, I know you're going to find the shocking bell. Where am I going with this?
You're going to go national patient ID. There you go.
The dark hole of every single piece of interoperability policies that we have to deal with. And so this has become, again, now I'm sure there's lots of providers that are doing things successfully, though I would hope they're going back and spot checking their state registries. Note to CIOs, if you haven't spot checked your registry, have your staff go do that. Make sure the data is actually in there, because we've gotten some very alarming stories in the past 2 weeks that we plan on sharing publicly. And we're not going to be naming any providers, but we're going to make sure that lawmakers and policymakers know that this isn't working necessarily as seamlessly as you can. And again, so because this data wrapped up in such a way where when they hit into the state database and they don't have all of the, patient information, because they can't use social security number, Bill, guess what they're doing? They're using data aggregators. Oh my golly. So here we go. It's like, if you had a patient identifier number, you wouldn't have to be, working with data aggregators to have a better match. So it all comes back to, not everything, but like lots of things come back to being able to accurately identify the patient or the consumer at the point of care. So these are the things when there's a lot of things with the vaccine administration that are not technology oriented. This is the piece that we're focusing on.
Yeah, it's that's interesting. I'm not going to go down that road. You so eloquently put the need for a national patient ID. The road I'm going to go down is I'm actually really optimistic. Most IT projects, most projects in general, start and they're bumpy, right? So we've acknowledged that they're bumpy to start. But I'm looking at this going 100 million vaccines in 100 days. This is the administration's stated goal and objective. We're already with all these bumps and bruises. I mean, according to the Washington Post, according to Bloomberg, according to the USA Today, we're at about 30 million people vaccinated. And that's with this, all these problems that you read in all these, I mean, this article included has a bunch of things like, oh, this is broken, this is broken, this is broken. Okay, great. And I agree with you. I don't put any nefarious, intentions behind any of this. I'm just saying, yeah, okay, you identified all things that are broken, but 30 some odd million people have been vaccinated, and that probably does not include the military, because we're probably not counting them in those numbers. And so you up that number by a fair amount. Let's just say you get to 35 million. 35 million have been vaccinated since December. We didn't have a huge quantity of the vaccine itself, and we had all these logistics issues. Okay, that's the start of the project, and that's not all that bad of a start. And to be honest with you, if the number of vaccines being produced continues in the direction, and yes, they were overstated in the beginning, and we all acknowledge that now, but still we're looking at the potential for almost 100 to 200 million doses being produced between the two, Pfizer and Moderna. And I'm not even including J&J at this point. So by April, we might be looking at 200 million doses being available in the US to be distributed. I'm really optimistic. I think we're going to have more of a problem once we get through everybody that wants the shot than we are going to have getting to 100 million people vaccinated. I think that number is going to be achieved, and it's going to be achieved relatively quick. I'd be surprised if we're not there by the president's stated date of April. What's the first 100 days? April 28th, roughly, for the administration. So I'd be surprised if we're not at that 100 million number. And with the 100 million number and the number of people who have already had who have had COVID and have developed some immunities to it, at least as far as we know, we're going to make a serious dent in this thing by the end of the spring, I think. So I'm very positive, even with all these negatives, even with all these challenges, that we are really making a dent in this. That's my personal view of this. Think I'm nuts?
I mean, like I said, I'm an optimist too. I mean, you've clearly given this a lot of thought. I can't say that I sit here and hand wring over, is everyone going to get vaccinated? Like, oh my gosh. Like, I mean, I'm just trying to focus on the here and now, Bill. And, we were just picking apart one problem. I mean, I think what we try to do is identify like the single biggest use case ever for patient identification, a pandemic, right? So I'm sure that we're the United States. We will figure this out. We will persevere and it will get done. I think, we'll have to do some, postmortem on this afterwards and just figure out like where we could have done things better. Heaven forbid we have another pandemic. That's even hard to even fathom, but I'm sure we'll get it done. I think we're just trying to figure out like along the way, how do we mitigate some of these bumps? My parents, for example, they're not snowbirds, but they are on Medicare. They live in Virginia, but their provider is in Washington, D.C. You have elderly patients who maybe lose their card, don't maybe know which vaccine they got. They got vaccine 1, but was it Moderna? Was it Pfizer? They're not sure. So you can see there's going to be some hiccups here, but I'm sure we'll figure it out. I just think that there's a lot we could do better.
Yeah, I'll tell you, health IT leaders who are wondering, Bill talked about systems that have QR codes and they're checking in and they're in and out in 10 minutes. Boy, that isn't us. What are we doing wrong? Reach out to CHIME, reach out to me. More than happy to connect you with health systems that really feel like they have this pretty well wired. And you have systems like Atrium that are doing mass vaccination events, CIC in Massachusetts, UC, University of Colorado Health System doing mass vaccinations in Colorado. So I think that's the next thing we're going to see. We're going to see these mass vaccination events. And, in order to do those, you have to have a pretty sound process for bringing people in, people that aren't necessarily in your EHR, tracking them. Now, if you're in a major metro, the reason the patient ID stuff doesn't resonate with me is we had to figure this out a long time ago. I mean, we had 15% of the people in our ERs did not have social security numbers. Let's just say it that way. So we had to figure out this patient matching and how do you handle people who are showing up for the first time, and how do you handle consumers that you're trying to reach out to that aren't necessarily going to be in your EMR and you're not going to track them. Now, granted, our budget was significant. We had 700 people in our IT department, and not everybody can do this, but there are absolutely ways around needing a national patient ID to do this effectively. But I agree with you. If you put it down on every health system, I've already sat across from CIOs who have 6 people on their staff that were doing the same thing my 700 people were doing. And that's just, there's no way you can do it. I agree. You have to rely on other people to do it. So I empathize and I appreciate it. Mari, thanks for your time. I really appreciate it. This was a fun conversation.
Sure. It's always nice to be invited on. So we really appreciate that opportunity. And it would be okay if I made a shameless plug for our information blocking center and would that be okay?
That would be fantastic. Go for it.
Okay. So again, we just launched our information blocking center. So it's informationblockingcenter.org. And then back to the point about patient ID, we actually have a patient ID coalition. And so, we welcome our members to join us, patientidnow.org. Yeah, and everyone hopefully knows where to find me, and we're happy to answer any questions and always happy to talk to a member. So thanks very much, Bill, for having me.
What a great discussion. If you know of someone that might benefit from our channel, from these kinds of discussions, please forward them a note. Perhaps your team, your staff. I know if I were a CIO today, I would have every one of my team members listening to this show. It's conference level value every week. They can subscribe on our website, thisweekhealth.com, or they can go wherever you listen to podcasts, Apple, Google, Overcast, which is what I use, Spotify, Stitcher, you name it, we're out there. They can find us. Go ahead, subscribe today, send a note to someone, and have them subscribe as well. We want to thank our channel sponsors who are investing in our mission to develop the next generation of health IT leaders. Those are VMware, Hillrom, Starbridge Advisors, Aruba, and McAfee. Thanks for listening. That's all for now.